Immune tolerance is the acquisition or a capability of non-reactivity toward self-antigens. That's what you call immunological tolerance of our immune system. So self-recognition or just self-tolerance is a very important process, and failure to recognize immunologic self-antigen can result in serious autoimmune disease. So autoimmune disease are a result of lack of immune tolerance to the self-antigen. So lack of immune tolerance to self-antigen is what you call autoimmune disease. So tolerance is initiated during fetal development. That type of tolerance is what we call a central tolerance, by the elimination of cells with the potential to react strongly with the self-antigen. So these cells are eliminated during fetal development, and this is what we call central tolerance. So whereas peripheral tolerance, it is peripheral lymphoid tissue tolerance, which is a process that involves mature lymphocytes and it occurs in circulation. So that is what we call peripheral tolerance. It occurs, of course, throughout our adulthood, but of course, central tolerance is a primitive and very fast tolerance, which happens during fetal development. So central tolerance develops in thymus during fetal life, where self-antigen are presented to dendritic cells. They are presented by dendritic cells to self-reactive T lymphocytes that are responsible for positive or negative selection for specific lymphocytes. So in this case now, a dendritic cell is able to present these antigens to specific lymphocytes, and dendritic cell is now able to perform positive or negative selection of those lymphocytes. So the ultimate goal is to remove T lymphocytes that are strongly or that respond strongly to self-antigen. So those lymphocytes must be removed from the immune system. So the ultimate goal of central tolerance check is to remove T lymphocytes that are responding strongly to self-antigen. So for autoimmunity to develop, there must be failure in the elimination of autoreactive cells. When there is failure to eliminate or remove T lymphocytes that are autoreacting, so that's what leads to autoimmunity. So if there is too little duration at any stage of development, an autoreactivity will happen. So, but too much duration also will end up in the reduction of or compromise of the protective repertoire. What is a protective repertoire? So immune repertoire or protective repertoire of immune system, this is a turnover or the number of cells that are ready to protect our body. So that is immune cell or immune protection cells. That is the combination or a set of those cells. It is what we call a protective repertoire. So if that immune selection is taking place and there is too much elimination of those cells, that can lead to compromise of protective repertoire of our body. So failure of tolerance can result also in autoimmune reaction to self-antigen. Sometimes also, as we described yesterday, hypersensitivity reaction also will occur because of failure to tolerate for some self-antigen or just normally harmless antigens. Sometimes antigens are harmless, but the body is not now able to tolerate to those harmless antigens. So that is what can lead to hypersensitivity reaction. How does self-tolerance maintained? So, to eliminate autoreactive cells and sustain the maintenance of self-tolerance, T and B lymphocyte have to undergo selection process during their maturation process, and that happens in primary lymphoid tissues. And you remember that primary lymphoid tissues for T lymphocyte, it is of course bone marrow and the thymus, and for B lymphocyte, it is bone marrow only. So that is where this selection process takes place in order to sustain or to maintain self-tolerance. So B cells undergo a second process of selection during their maturation. So B lymphocyte will also undergo a type of selection during their maturation. So signal for survival are also called positive selection. So there will be signal for survival, which means now a cell is ready to grow and become a mature functional cell, which means a cell is not reacting to self-antigen. So it will receive a command which we call signal for survival. So signal for survival means the cell now is going to be positively selected. It means the cell is not going to be destroyed, but is going to proceed throughout maturation process. So T lymphocytes in the thymus that lack any affinity for self-peptide self-major histocompatibility complex are also eliminated. Right? This one is clear. So those are the T lymphocytes that lack affinity for self-peptides self-major histocompatibility complex. So this is going also to be eliminated because it will not be able to recognize a major histocompatibility, which is very important, especially for T lymphocytes. So they can be able to receive receive signals from antigen presenting cell, and this is of course it requires always major histocompatibility complex. This process occurs in the bone marrow and continues in the spleen, where B lymphocytes migrate as transitional cells after exiting the bone marrow. So highly autoreactive B lymphocytes are negatively selected on self-antigen encountered during early maturation. So this is what happens, especially for highly autoreactive B lymphocytes, and they can just be always negatively removed from the pool very early during their maturation process. So that is what we call central tolerance. You know that central tolerance is happening very early, and it is taking place in primary lymphoid tissues, bone marrow, and the thymus. So, but unlike the central tolerance, so peripheral tolerance is also another selection, is the second selection, negative selection or positive selection, which takes place in peripheral lymphoid tissues as well as in primary lymphoid tissues, sometimes permitting the removal of autoreactive cells that don't encounter autoantigens in the thymus or bone marrow. For example, any cell that did not encounter autoantigen in the thymus and bone marrow can undergo the second tolerance check in peripheral lymphoid tissues, so in order to be eliminated if it is really autoreactive. Now, so that's what we call immune tolerance, right? So immune tolerance, it is the capacity of our immune system to recognize self-antigen and to tolerate towards self-antigens. But of course, when that tolerance fails, of course, the tolerance which happens in two phases, central tolerance that happens during fetal development, and peripheral tolerance that happens in time. So central tolerance involves the bone marrow and the thymus, which is of course lymphoid tissues, primary lymphoid tissues, whereas peripheral tolerance involves peripheral lymphoid tissues. So, and it always use those cells that were not able to encounter autoantigens in the primary checkup, thymus and bone marrow, and these cells are going now to be exposed to second antigens. Now, if a failure of any of the two tolerance checkup happens, then it leads to autoimmune disease. And what is autoimmune disease? So autoimmune disease is normally used when we want to demonstrate that autoantibodies or cytotoxic T lymphocytes are playing a role of are displaying specificity for self-antigen or autoantigen and are contributing to pathogenesis of disease. That is what we call autoimmune disease. This is when the first thing is autoantibodies. Secondly, cytotoxic T lymphocytes are expressing specificity for self-antigen, which means they are targeting or they are reacting towards self-antigen or autoantigens. So the hallmark of autoimmune disease is tissue injury, which is caused by T lymphocytes or antibody reactivity to immunologic self. So then immune activation may be initiated by infection, or activation of immune system is in the absence of any external threat. Immune system is somehow strange. Sometimes autoimmune disease, some of autoimmune disease that we know, they are preceded and initiated by viral infection. For example, viral infections. So some virus can activate autoimmune disease. For example, HIV, human lymphotropic virus. Those can actually contribute to the initiation of autoimmune diseases. But also sometimes autoimmune disease can happen without any external threats. Okay, now we are going now to break down these autoimmune diseases, starting from organ-specific and mid-spectrum diseases. So organ-specific, it means these conditions now we are going to discuss here, they are only confined at certain organs. They're organ-specific. For example, Hashimoto disease, that is organ-specific because it is actually confined in the thymus, in the thyroid gland. That is Hashimoto disease. But also, some of these are mid-spectrum. They are not really organ specific. They can be organ specific, but sometimes we find them they are extending to nearby organs or tissues. So they are no longer organ specific, but they are also not systemic. That's why we call them also mid-spectrum conditions. So the first one is cardiovascular diseases. So we have some autoimmune cardiovascular diseases. So the primary immunologic disease of the blood vessels, that of course cardiovascular, this involves cardiac and blood vessels. So we have what we call vasculitis. And vasculitis, it is an immunologic inflammatory condition of blood vessels. So that also affects heart, which are called cardiitis. Cardiitis are also other autoimmune conditions that leads to inflammation of heart. Vasculitis, it involves deposition of circulating immune complex, which is responsible for many forms of vasculitis. So there are different causes of immune complex deposition, of course. As you remember, some of the hypersensitivity reactions, some conditions, some diseases can lead to the accumulation of immune complex anywhere, of course, in the blood vessels, which leads to vasculitis. So the inflammatory region produce variable injury or necrosis of blood vessels, and of course, this may result in narrowing of blood vessels, occlusion of blood vessels, and production of thrombi, the thrombosis of the lumen, or aneurysm formation and rupture of the blood vessel. That is the effects of this vasculitis or inflammation of the blood vessel. So here we are able to find anti-endothelial antibodies. And remember what is endothelium? Endothelium is inner layer of the vascula intima. That is what you call endothelium. So we find anti-endothelial antibodies that are contributing to this problem. Those anti-endothelial antibodies are targeting cytoplasmic membrane of endothelial cell in the endothelium. So the second, apart from vasculitis, we have also cardiitis. Cardiitis, it is inflammation of cells within myocardium resulting from immune sensitization to the endogenous or exogenous cardiac antigen. It can just be an endogenous cardiac antigen, because this is a type of autoimmune disease. It can also be even exogenous stimulation, exogenous cardiac antigen that are stimulating cardiitis. So cardiitis can be caused by so many conditions, for example, acute rheumatoid fever, Lyme disease, cardiac transplant rejection. So what happens? Myocardial contractility can be impaired by cell-mediated injury or local release of cytokines. Patients with rheumatic heart disease will exhibit anti-myocardial antibodies that binds in vitro to foci in the myocardium and heart valves. So the autoantibodies appear to be very strongly cross-reactive with streptococcal antigen, but they are not toxic to heart tissue unless the latter is damaged previously by some other causes. So the presence of myocardial antibodies is diagnostic, especially for autoimmune cardiitis, which is, of course, Dessler syndrome. Dessler syndrome, it is cardiac injury or rheumatoid fever. You find anti-myocardial antibodies. Anti-myocardial antibodies are diagnostic of cardiac injury or cardiitis. So these are the kind of antibodies. That is, of course, what you need to understand. You need to understand a type of antibodies that you are able to find in a particular autoimmune disease, and even cellular involvement if it is, because sometimes there is no cellular involvement. But if cellular involvement, then you should also understand that mechanism. The second group of mid-spectrum condition, it is collagen vascular disease. So collagen vascular disease is one of them. For example, progressive systemic sclerosis. Progressive systemic sclerosis, it is also called scleroderma. So the scleroderma or PSS, sometimes, of course, in immunology we like to use just letters P, S, S, but sometimes progressive systemic sclerosis. So PSS, in short, that is how we call it. So when you see PSS, so PSS is just a collagen vascular disease of unknown cause that assume various form, and you find this is collagen vascular disease. It is affecting blood vessels and also tissues, in which, of course, we find collagen. So you find also that eosinophilic fasciitis is also one of these PSS conditions. So this is a group or a set of collagen vascular diseases. So the development of scleroderma has been associated with drugs, for example, bromycin, sulfate, tryptophan, and carbidopa, and the occupational exposure to vinyl chloride and also vibratory stimuli and silicosis has been associated with developments of PSS. So epidemiology of PSS, so it occurs in all races, but it is three times more frequently in women than in men. So that is true about most of these autoimmune disorders. They affect women more than men. So signs and symptoms of the PSS or systemic progressive systemic scleroderma, it is is a chronic multisystem disease, of course, which is characterized by thickening of the skin, which is of course called scleroderma. And this scleroderma is characterized by fibrous in the skin, internal organ fibroids, and arterial occlusions, which is with a distinct proliferation pattern. So, as you can see, most of internal organs are affected, but also this issue starts from skin, and skin becomes fibroid, which progress even to internal organs and even blood vessels occlusions. So this is the effects of PSS as an autoimmune disease. So initial symptoms usually occur later in life, and Raynaud's phenomena, which most frequently occur before the onset of manifestations, but articular complaints are very common. Hypomotility of the GI tract is also another common feature. So hypomotility, that is bowel movement. So bowel movement is very low. So the disease is slowly progressive and chronically disabling, but can be rapidly and progressively fatal. It can be fatal, and it can be very rapid in progression, but in most cases it is very slow, which can be disabling chronically. So now, apart from this, immunologic manifestation in the scleroderma can be also a tricky question you should also expect. So idiopathic scleroderma is always considered as autoimmune disease because of the association with the autoantibody, but antinuclear antibodies are formed in scleroderma, and those are at least in 40 to 90% of patients. You find these antinuclear antibodies are formed. The first antinuclear antibody that we know here, it is what we call extractable nuclear antigens antibody, of course, anti-extractable nuclear antigen. The second antibody is called the antinucleolus antibody, and then anticentromere antibody, and SCL70. So these four major antinuclear antibodies that are formed in PSS are seen in the patients. So the anticentromere antibodies is sensitive and specific for patients with a subset that we call CREST syndrome. So someone can also have this scleroderma with the subset of CREST syndrome, and you find the patients are experiencing calcinosis, Raynaud phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. So this, if patient is showing this syndrome, CREST syndrome, this is associated with anticentromere, and anticentromere antibody is going to be our antibody to confirm the presence of scleroderma with CREST syndrome. So activated lymphocytes can result in both the vascular change and increase in collagen production in scleroderma, and vascular injury can be mediated by cytokines or even direct cell-to-cell interaction by activated lymphocytes and endothelial cell. So activated lymphocytes, they can interact with the endothelial cell, and this can lead to scleroderma formation in the blood vessels, and also destruction and production of collagen. So the second mid-spectrum condition, it is called eosinophilia myalgia syndrome. So because many people are exposed to the agent causing eosinophilia myalgia syndrome, or EMS, may develop illness. So more than 50% of patients with EMS develop scleroderma-like manifestations. The most important predictor is ingestion of contaminated L-tryptophan drug, So this patient will also develop eosinophilia along with other classic scleroderma manifestations. So the third group of disease, those are the diseases that affect thyroid gland. So those are, of course, endocrine gland diseases. So there are two major forms of autoimmune endocrine disease or autoimmune thyroid disease. The first is called chronic autoimmune thyroiditis, and the second is called Graves' disease. So the first, which is also called Hashimoto disease, it is a lymphoid chronic thyroiditis. So the cause of Hashimoto disease is not known, but it is believed to be related to autoimmune process in which the development of circulating cytotoxic antibody eventually destroy the thyroid gland, producing hypothyroidism. So Hashimoto disease leads to hypothyroidism because of the destruction of the thyroid gland because of development of cytotoxic antibodies. So those are the antibodies that are able to destroy cells. Signs and symptoms here of lymphoid thyroiditis is believed to be the most common cause of sporadic goiter. So you remember that Hashimoto disease is of course associated with sporadic goiter, and there is also a firm, diffusely enlarged, non-tender thyroid gland and may be lobulated. So that's what we call goiter. And hypothyroidism, however, is a late sequelae, and patients are usually thyroid when first visit physician. They are thyroid, which means hyperthyroidism in Hashimoto disease. It normally occurs when someone is at very, very serious stage of disease. So immunologic manifestation we find in Hashimoto disease or chronic thyroiditis. So because this condition is an autoimmune disease, we find a number of antibody to different parts of thyroid gland. For example, anti-thyroglobulin antibodies, anti-thyroid microsome antibody, anti-second colloid antigen antibody, as well as anti-thyroid membrane receptors antibodies. So we find this list of antibodies that are involving in chronic thyroiditis, and even antibodies that detects or binds thyroxine and 3-iodothyronine. These are the hormones of thyroid gland. We also have antibodies against these hormones. So that is also another manifestation or another finding in this autoimmune disease. Diagnostic evaluation, of course, you remember that because of the presence of goiter, you need to perform a final needle aspiration technique, and then we demonstrate variable infiltration of the entire gland with the lymphocytes. So goiter, when you take goiter maybe through FNA or just biopsy, you find that there is it is very packed with lymphocytes. So anti-thyroglobulin antibody, or what you call antibody against anti-thyroid or thyroid microsomal antibodies, are found in moderate to high titer in more than 50% of patients, but the presence of antimicrosomal antibodies is not more diagnostic, is considered more diagnostic. So the presence of antimicrosomal antibodies, so these antimicrosomal antibodies are antibodies in Hashimoto disease, and to detect this one can be more reliable diagnostic. Whereas, of course, also anti-thyroglobulin are also present, antimicrosomal antibodies are also present, and so on. So the second is called grave disease. So grave disease is also another form of thyroid autoimmune disease, but this can lead to hyperthyroidism, unlike Hashimoto disease, which of course leads to hypothyroidism. So hyperthyroidism associated with the grave disease. So it is when you are able to demonstrate low TSH and elevated free T4 levels. When you are able to demonstrate this, then it means this is hyperthyroidism. So of patients with the grave disease, 50% of them exhibit antibodies against thyroid peroxidase. You know that thyroid peroxidase is what is involved in the formation of antibodies of hormones, of course, by binding iodide to thyroglobulin protein, so which is a precursor of those hormones. Sometimes also, of course, but not sometimes, but always, almost always, TSH receptor antibodies are also seen, and this is going to help us discriminate between grave disease and nodular goiter. So the presence of TSH receptor antibodies. So those are the antibodies that affect TSH receptor in thyroid gland. Some other mid-spectrum autoimmune disease also include, of course, pancreatic disease, that is insulin-dependent diabetes mellitus type 1, of course. Etiology of this is caused by immune destruction of B lymphocytes, beta cells of the pancreatic islets. So that is immune destruction of the beta cells of the pancreatic islets. And the only definitive identified environmental factor causing type 1 diabetes mellitus, it is congenital rubella infection. If someone has congenital rubella infection, so their children would also suffer this type 1 diabetes. It is one independent contributing factor. So infection with Coxsackie virus B may be another trigger, and type 1 diabetes mellitus is associated with various human leukocyte antigen DR, D4, DR4, and DQ2 and DQ8. So CD4 plus CD4 site, of course, these are T helper cells, are implicated as essential in the immune response against this pancreas, which leads to diabetes. So those cells that are involved, they are not cytotoxic cells, but they are T helper cells, the CD4 plus cells. So immunologic manifestation of type 1 diabetes mellitus, you find the T lymphocytes that are responsible for initiating immune response to the islets that result in autoantibodies, autoimmune destruction of CD4 plus cells. So the B cell destruction will also occur. So patients with the type 1 diabetes mellitus have the following type of autoantibodies. Of course, the first autoantibodies you find in type 1 diabetes mellitus is insulin autoantibodies, that is antibody against insulin as a protein. The second is antibody against glutamic acid decarboxylase enzyme, and also antibodies against islet cell antigen. So those are the antibodies we are most commonly seen in children born with type 1 diabetes mellitus, of course, because of the destruction of the pancreas and lack of beta islets, pool of cells for production of insulin that is of course responsible for sugar maintenance in the body. So autoimmune pancreatitis is of course different. It is a very, very different because both of them can affect the pancreas, but autoimmune pancreatitis will not lead to diabetes mellitus. This is going to lead to other conditions, for example, lack of lipase responsible for digestion, and patient experience maldigestion. So autoimmune pancreatitis is characterized by autoimmune inflammatory process in which prominent lymphocyte filtration with the associated fibrosis of the pancreas can cause organ dysfunction. So autoimmune pancreatitis, because of autoimmune inflammatory process and infiltration of lymphocyte in that organ. So infiltration of lymphocyte is because lymphocytes are disturbing this organ, which leads to dysfunction. So autoimmune pancreatitis, even though the cause of the disease is not known, but sometimes it is thought to be a systemic autoimmune disease associated with other autoimmune diseases. So signs include they are variable, but many patients manifest very jaundice and abdominal pain. And if you take histologic examination of the pancreas tissue, that is histology examination, you find a color like periductal infiltrates composed of lymphocyte and plasma cells, of course, in the pancreatic tissue examination. So apart from the cell infiltration, we find also immunologic manifestation, humoral immunology. The immunologic abnormality includes, first of all, hypergammaglobulinemia, elevated serum Ig4 concentrations in patients with diffuse and large pancreas, and also autoantibodies against different parts of the pancreas. Those antibodies against carbonic anhydrase 2, lactoferrin, anti-smooth muscle antibodies, and even anti-nuclear antibodies can also be seen. Increased number of CD4 plus cells in peripheral blood will also be seen as well. So we have also adrenal gland. Adrenal gland, you know what we call Addison disease and Cushing syndrome, and Cushing disease, of course. So Addison disease, it is caused by idiopathic adrenal atrophy. Idiopathic adrenal atrophy. This causes Addison disease. So women are affected twice as often as men, and adult form of Addison disease is associated with human leukocyte antigen class 2 antigens. Those are, of course, HRA class 2 antigen on DR3 and DR4 are those that are involved with autoantibodies. So 80% of patients will manifest serum antibody against cortical elements, and sometimes even others manifest antibodies against microsomal. Some patients will also demonstrate antibodies against adrenal cortex. So those are all possible antibodies that can be shown in this condition, adrenal gland conditions. So in women with the premature ovarian failure, autoimmune destruction of the ovarian stroma can also be seen in this screening. So apart from that, we have also reproductive diseases. Reproductive diseases. So the prevalence of smooth muscle antibody, anti-nuclear antibodies, anti-phospholipid antibodies have been found in women with unexplained infertility. There are some women with the infertility, but that infertility is at least explainable. But here, in some women with unexplained infertility, sometimes you find the presence of anti-smooth muscle antibodies, anti-nuclear antibodies, antiphospholipid antibodies, but also autoantibodies to the ovary and gonadotropin receptor, which exist in many women with polyendocrinopathies. So polyendocrinopathies are a type of women with very many endocrine problems, very many endocrine disorders. So the fetus is immunogenic allograft that can evoke protective immune response of the mother. So in this case now, the mechanism of pregnancy loss involves antiphospholipid antibodies, especially when there is a stimulation of the fetus to the mother, which leads to the rejection of that fetus. So that fetus is acting as a allograft. So allograft is just a graft from someone else. So even that fetus is acting as allograft, which is initiating immune response of the mother. So lupus anticoagulants and anticardiolipin antibodies are detected against platelet vascular endothelium, and this can cause vascular destruction and thrombosis, leading to death and abortion. And so finally, we have the last one in this presentation. It is exocrine gland disease. So apart from those, some of the endocrine, those ones that produce hormones, now we are going to look at exocrine gland autoimmunity. So the first one that affects exocrine gland, for example, lacrimal gland, salivary gland. So it is called Sjogren syndrome. Sjogren's syndrome. So Sjogren syndrome is also a chronic inflammatory disease that causes lacrimal salivary gland problems. It results in keratoconjunctivitis, sicca, and also xerostomia in patients. As with the rheumatoid arthritis and systemic lupus, causative factors include infection, abnormality of regulation, and genetic factors. So signs and symptoms of Sjogren syndrome, it starts with eyes, with the dry eye, dry mouth, recurrent salivary gland pain and swelling, and even hoarseness of voice, chronic cough, and increase in incidence of infection as well in these patients with the Sjogren syndrome. So another thing that happens is dryness of the vagina, which leads to dyspareunia and itching. So dyspareunia is pain after sex. After sex, it is called dyspareunia, and itching is common. So dysphagia and atrophic gastritis can also be present. So renal tubular acidosis and vasculitis involving the peripheral nerves and central nervous system can also result from Sjogren syndrome. There are so many manifestations. It is not a systemic disease, but it is a bit wider spectrum infection. Autoimmune disease, which affects various parts of the body, causing renal tubular acidosis and vasculitis, and even atrophic gastritis, and so on. But immunologic manifestation is very important in Sjogren syndrome. And what I'm going to see in Sjogren syndrome, of course, it is hypergammaglobulinemia, rheumatoid factor, as well as autoantibodies to salivary ducts and other antigens. So lymphocyte and plasma cell infiltration involved in tissues. So antibodies are usually polyclonal and may result in hyperviscosity syndrome and hypergammaglobulinemic papilla. So because this patient with the Sjogren syndrome, they tend to produce so many gamma globulin, in which we call hypergammaglobulinemia, as well as also hyperviscosity syndrome because of the accumulation of gamma globulins. Of course, those are antibodies. You find speckled, you find even homogeneous antinuclear antibody pattern in at least 60% of patients. So rheumatoid fever is also present. So rheumatoid fever is also very common in Sjogren syndrome. In 90% of cases, you find a rheumatoid factor. So a rather new autoantibody, which is anti-alpha-fondrin, has also been seen in Sjogren syndrome, and autoantibody to salivary duct antigen are detected in patients with the secondary Sjogren syndrome. So anti-mitochondrial antibodies are also seen, but in very few patients. But patients with the Sjogren syndrome also may have higher level of antibodies to the thyroid gland, gastric parietal cells, pancreatic epithelial cells, as well as smooth muscle, because of this Sjogren syndrome. So they have tendency to fall into these conditions. So lymphocytic infiltration of the exocrine gland of the eye, mouth, nose, lower respiratory tract is also another immunologic manifestation. So lymphocytic infiltration of those exocrine gland of the eye, mouth, nose, and lower respiratory tract. So and their tracts as well as vagina. So I don't think this one is really easy. So infiltration of lymphocytes in this organ is something hard to imagine. So the infiltration is composed of B and T lymphocytes, and most commonly in T lymphocytes, you find that T helper cells are predominating. So we have also gastrointestinal disease, of course, for example, atrophic gastritis and pernicious anemia. Remember that pernicious anemia, it is autoimmune gastritis, which is, of course, which leads to the autoantibodies that are able to recognize and destroy intrinsic factor. So intrinsic factor is required in order to prevent from pernicious anemia, because intrinsic factor is a carrier of vitamin B12. So if intrinsic factor is not produced because of autoimmune disorder, so then there will be a problem of pernicious anemia, which is, of course, a part of megaloblastic anemia. So immunological finding, of course, you find antibodies against some parts of the parietal cells, including lipoproteins, cytoplasmic components, intrinsic factor, and so on. But in histological finding, we actually find destruction of the gastric mucosa and lymphocytic infiltration and the absence of parietal cell and chief cells. That is what we see on tissue histologically, but also in immunological way, we are able to show antibodies against parts of the gastric parietal cells and also their products, which is intrinsic factor. So pernicious anemia, of course, it is normally associated 100% with antibody against intrinsic factor. Those are the intrinsic factor antibodies, and those are also autoantibodies. So you find also in these patients, you find that most patients with the pernicious anemia, they show also importantly parietal cell and antibodies. So apart from antibodies against intrinsic factor, you find also these patients, they also have parietal cell antibodies or autoantibodies against parietal cells of the gastric mucosa. So thank you so much for joining this session and really your attention. So I really appreciate. So I hope to see you soon in the subsequent video. Most welcome. That is tomorrow in the same time, the same hour. God bless you, and thank you so much. Have a great night.